In this video, we're going to talk about hypoxic vasoconstriction. And we're going to talk about hypoxic vasoconstriction in the perspective of how does this lead to pulmonary hypertension. So hypoxic vasoconstriction is meant to be a compensatory mechanism that serves a purpose in the short term. So if we have something like a respiratory infection, say, where we've got an increase in mucus in our alveoli, the purpose of hypoxic vasoconstriction is meant to take a look at our vasculature, the blood supply to these alveoli. And if we have an area of poor ventilation, the whole idea is why would we not constrict the vessels in that area of poor oxygenation or poor ventilation, shift the blood supply over to an area where there is better blood supply or better ventilation. So shift that blood supply over to somewhere that is better ventilation. And as a result, we'll get better oxygenation or more oxygen in that blood. The problem that exists here is twofold when we're looking at something like pulmonary hypertension or how that hypoxic vasoconstriction leads to pulmonary hypertension is that this is not meant to be a chronic mechanism that's involved. So when we have hypoxic vasoconstriction over the long term, it can lead to pulmonary hypertension because A, it's only meant to be a short-term compensatory mechanism, and B, it can lead to some fairly dramatic remodeling in the vascular smooth muscle, which can lead to some of the issues we see. So let's start taking a look at some of those issues. So how does hypoxic vasoconstriction lead to pulmonary hypertension? And one of the first things, one of the first mechanisms we're going to talk about is how that hypoxia actually impacts ion flow. So we need to recognize that hypoxia is actually going to have an impact on ion flow. And if we have an impact on ion flow, then we're going to have an impact on things like depolarization, cell membrane potential, and opening and closing of ion channels. So what I want to do is I want to kind of blow up some of the vascular smooth muscle here. So we're looking at the vascular smooth muscle within our lungs. And we want to look at, well, what's going to happen on those cells? So I'm going to draw in a box here, and we're going to draw essentially a single cell of the vascular smooth muscle. So what I want you to picture here is this is the cell of the vascular smooth muscle. We know that on that cell, we're going to have a number of different ion channels. So here in green, we're going to talk about voltage-gated potassium channels. So these are the channels that are responsible for potassium efflux following depolarization. So remember, we're looking at the channels that are involved in potassium efflux in order to hyperpolarize the cell following depolarization. And we're also going to talk about how this might impact something like a calcium channel. So we're also going to look at calcium channels here. So the two core channels we're going to look at in terms of the impact of hypoxia are potassium and calcium channels. And what we find is that during hypoxia, we see a decrease in function of our voltage-gated potassium channels. So hypoxia actually leads to a decreased function of our potassium-gated or our voltage-gated potassium channels, a decreased function of our voltage-gated potassium channels. And what this means is that they will struggle or we'll see a reduction in opening in order to allow for potassium exit. So we actually see protein changes on these channels when we experience hypoxia. And the consequence of this, or what we start to see happening as a result, is that these channels do not want to open as well during or after depolarization. So we see failure of these channels following depolarization. And what that means is that more potassium remains in the cell following depolarization. So decreased function of the voltage-gated potassium channel leads to an increased retention of potassium, so increased retention of potassium following depolarization. So increased retention of potassium after depolarization. And if you think of what this means for the patient is that we are going to see an increase in the amount of potassium within the cell, which makes the cell more positive. So the consequence if we retain all this potassium is we actually increase our resting membrane potential, or we have a more positive resting membrane potential. And if we have a more positive resting membrane potential, we are always closer to threshold. And what that means is that we can have an action potential more readily. And that's exactly what you see for these patients. And what we see in the vascular smooth muscle is that because we're closer to threshold, we see increased potential for action potential. And then because of that increased potential, or because of that increased opportunity for action potential, we actually see increased opening of calcium channels during depolarization. So increased potential for action potential, increased depolarization, which means we're going to see increased opening of our calcium channels. And that is what's going to lead to vasoconstriction. As that calcium enters, binds actin myosin, it's going to lead to constriction. So we see an increase in vasoconstriction. So increased opening of calcium channels, which is simply going to promote more muscle strength or the more muscle contraction, which leads to constriction of the vessel. So the consequence here, what the consequence we're going to see is we get increased contraction, which leads to vasoconstriction. So again, if we think about the physiological purpose here is in the presence of hypoxia, we have less function of our voltage-gated potassium channel, which means we can't have as much potassium escaping the cell. That increases the positivity of the cell and is actually going to promote an increase in calcium ion flow into the cell, which will increase contraction. If we think about, again, physiological purpose, that would be to promote this vasoconstriction, to have blood shunted towards areas of better or more oxygenation in order to promote better supply of oxygen to the blood. So that's one of the challenges, or one of the things that we see when we're hypoxic in the pulmonary system, which leads to hypoxic vasoconstriction. One of the problems with this is it's, again, not meant to be a long-term solution. So the longer this goes on, or the more pervasive the respiratory problem is, so picture someone who has, say, a pneumonia in this entire lung, or has chronic bronchitis and has had that chronic bronchitis for years. This is now happening in the entire system rather than a localized area of the system, which can be very negative for the patient. The second thing we'll see happening for these patients is an increase in remodeling of the vasculature. This happens for a number of reasons. So if we start looking at the vasculature as a whole, we know that we have the endothelial lining as well as the smooth muscle that's going to support these cells. And what starts to happen is we start to see remodeling of the vessel itself as well as the smooth muscle. And there are a number of reasons why we're going to see this. One is going to relate to the vasoconstriction that we have. So if we have long-term vasoconstriction, where we're chronically activating these muscles to cause vasoconstriction, one of the things that we're going to see is an increase in hypertrophy of these muscles. And that's exactly what happens here. So in terms of remodeling, one of the things that we see is chronic activation leads to hypertrophy of our vascular smooth muscle. And the consequence of that is going to be twofold. Is one, that it can actually lead to an impairment or an impingement on our lumen size. So picture these muscles getting bigger and thicker. One of the challenges that can exist is we can actually start to see some compression or some movement in towards the lumen, which can reduce lumen size and obviously increase the amount of resistance in there and cause some pulmonary hypertension. And we just get more forceful contraction. So we're actually going to see an increased inability to contract as we have hypertrophy of this muscle. So again, two consequences to this. One could be a reduction in lumen size, and the other is going to be that we can get a more forceful contraction. And that more forceful contraction can lead to stronger constriction of those vessels. Now, that's not all. When we start to see hypoxia of this tissue, so again, remember, part of the challenge here is that we've got some ischemia, and this tissue is becoming hypoxic and ischemic, and it's going to, as a result, start to release some of the cell mediators related or that are going to be associated with hypoxia and ischemia of this tissue. And we see just that. So what we start to see released from this damaged tissue are our platelet-derived growth factors, our fibroblast growth factors, which are going to change the makeup or the contributing makeup of this tissue. So as a result of hypoxia, we start to see the release of growth factors. So that includes things, again, like a platelet-derived growth factor or a fibroblast growth factor. So hypoxia leads to release of growth factors. And those growth factors are going to cause a few particular issues. One is that we start to see an increase in smooth muscle cells. So we actually start to proliferate the smooth muscle cells, or we start to see an increase in smooth muscle cells. So one of the things we start to see is an increase in smooth muscle cells. We are also going to see an increase in matrix deposition. So I want you to think about things like elastin and collagen. So we start to see an increase in matrix deposition. And again, one of the consequences of this is we just have more things or more cells in the area of the lumen, which is going to impinge on the lumen size and reduce lumen size here. So one of the other things that's going to happen is that we start to have increased deposition of our matrix, which will lead to thickening, or is going to at least contribute to thickening of this endothelial cell wall, or basically impingement onto this lumen. So we start to see increased matrix deposition, which is also going to be an issue. And then finally, we're going to pair that with our hypertrophy. So we get hypertrophy, we get an increase in smooth muscle cells, and we have matrix deposition, which will reduce lumen size. The other problem that is going to exist here in terms of remodeling is that we know when we have hypoxia or oxidative stress, that is going to lead to inflammation. So one of the other consequences here, so that kind of goes along with this remodeling, is that hypoxia is going to lead to an increase in oxidative stress. And as a result, that's going to lead to inflammatory mediator release, which has some impact here. So what we see is in terms of remodeling is we also have an increase in oxidative stress. An increase in oxidative stress is going to promote inflammation. And that promotion of inflammation is going to cause a couple of things. One is that this is one of the things that's going to promote fibrosis of this tissue. So we start to see some fibrosis of this tissue, which again will typically further increase the impingement onto the lumen. So we're going to see some fibrosis. The other problem is that the release of inflammatory mediators is also going to promote things like an increase in smooth muscle cells, an increase in matrix deposition. So that pro-inflammatory process that we get will lead to an increase in fibrosis. And we also make these things that we've already talked about worse. So the problem is that this will become a cyclic process where it's essentially going to dramatically increase the longer it goes on. So the second problem that we have here is an increase in remodeling. We know we get increased vasoconstriction because we have an increase in resting memory potential. We're more prone to contraction. So calcium is entering more frequently, which is leading to stronger and more regular contraction. The more we're doing this, or the more that this is a long-term thing, the more likely we're going to have hypertrophy of our smooth muscle. And that hypertrophy is going to lead to a thicker muscle, which leaves less space in the lumen itself, as well as a thicker muscle that can contract harder. And we know that if we haven't fixed the respiratory problem, so someone who has COPD, for example, we haven't fixed that respiratory problem, we're prone to contraction. So those bigger muscles are contracting more. The other challenge that we see here is that hypoxia leads to the release of growth factors. So things like our platelet-derived growth factor, fibroblast growth factor, and we get an increase in smooth muscle cells. So not only do we have hypertrophy, but we have hyperplasia of smooth muscle cells, which again promotes stronger contraction and less space in the vascular lumen. And we also see matrix deposition. So things like elastin and collagen being deposed into that matrix more, as well as fibrosis. So we start bringing in all these kind of pro-inflammatory cells, which are going to increase the size of the endothelium and the vascular smooth muscle and decrease the space in the lumen. So basically we get thicker pipes with less lumen size. Now, finally, that hypoxia causing a release of growth factors is also going to cause dysfunction of our endothelium. So the lack of oxygen to these tissues will lead to endothelial dysfunction, which is going to have an impact on our vasoconstriction as well. So we see endothelial dysfunction as a result of hypoxia. And the consequences of this are twofold. One is that we see reduced production of things that would typically cause vasodilation. So one of the consequences here is that we actually start to see a decrease in production of nitrous oxide and prostacyclin. Again, these are going to be two fairly strong vasodilators found in the respiratory system or in the respiratory vasculature. And as a result, we're going to see a reduction in vasodilation. So what this means is if I have a reduction in production of nitrous oxide and prostacyclin, I get a decrease in vasodilation. So I'm now favoring vasoconstriction. The other problem is that I actually promote the production of vasoconstrictors. So when I get endothelial dysfunction, we actually see an increased production of our endothelin. And endothelin here is a vasoconstrictor. So we see an increase in vasoconstriction. So again, if we start thinking about the holistic role this plays, is that one of the first problems with the hypoxia is that I promote contraction. I can't get my potassium out of my cells, becomes more positive, calcium flows in, I get vasoconstriction, and I'm going to have contraction of those muscles. If I think about this, so this prolonged hypoxia and living in a state of less vasodilation and more promotion of contraction, it's going to make this vasoconstriction worse that we see up here, which is going to make our remodeling even worse. And it is going to be a very cyclic process towards pulmonary hypertension. And that's exactly what we see for these patients, is that the longer this goes on, the more these three things can work together and can promote an increase in vascular resistance, which is going to lead to an increased amount of pressure in the pulmonary circuit. Now, the consequence of this typically lives on the right ventricle. So if we draw the heart in here, we can think about what the impact is going to be. So we know that it is our pulmonary artery that's going to be pushing fluid or pushing blood out to the pulmonary circuit. And as pressure increases here, so we've just talked about lots of things that lead to pulmonary vascular vasoconstriction. And the consequence of this is going to be an increase in pressure in the pulmonary system. So what we have to appreciate is that we have an increase in pressure that lives within this pulmonary circuit. So increased pressure that lives in the pulmonary circuit, which means that my right ventricle is going to have to be pushing against increased pressure, or the workload goes up. And that's the big consequence we see here, is an increase in workload or afterload on the right ventricle. So afterload has essentially gone up here. So the afterload on the right ventricle has gone up, and that means that this right ventricle is prone to having to pump much harder. And the consequence we typically see of this is hypertrophy of this right ventricle. And I have a video that I can talk about this in a little bit more detail, but we get hypertrophy of this right ventricle, which means that it is not going to have as much space for filling. So one of the consequences here is we see a right ventricle that typically has lots of space for filling that remodels, we get hypertrophy, and what happens is all of this space is taken up by muscle, and we have a dramatic reduction in filling space. So before, where all of that highlighted area would be filling space, now only a small fraction of it is. So we have a reduction in filling space, which is going to lead to a reduction in output. And you may be thinking, well, what is the consequence here? What does this have to do with hypoxic vasoconstriction other than being a consequence of it? Well, it actually promotes pulmonary hypertension even more. And the reason for that is that if we have any reduction in cardiac output, what we'll typically see is activation of things like our RAS. So falling cardiac output leads to compensation in the form of the renin-angiotensin-aldosterone system, which means that I'm going to increase angiotensin function, which means more angiotensin 2 and more vasoconstriction. I'm going to increase fluid retention, which is going to mean that's going to be more fluid in the system. And I'm going to increase my sympathetic nervous system tone, so an increase in SNS tone, which also is going to lead to an increase in vasoconstriction. So again, if we think about consequences, we've now added one more piece to this puzzle, which is further promoting vasoconstriction, further promoting remodeling, and at the end of the day is going to lead to a reduction in lumen size, which will lead to higher pulmonary vascular resistance. Now, if that wasn't enough, what we typically see in a chronic state of hypoxia is polycythemia. So what's going to happen for these patients is this chronic state of hypoxia actually promotes or increases red blood cell creation, and that increase in red blood cell creation is going to increase the viscosity of the blood. So if we have a more viscous blood, that means that our resistance typically goes up. So we start to see an increase in red blood cells, which also increases viscosity. So now not only do I have an increase in pulmonary vascular resistance because I have a reduction in lumen size, I've got remodeling of the vasculature, I have a consistent amount of vasoconstriction. Now I'm trying to push all of these thick red blood cells through, or this thick blood through the area, which is leading to even further increases in resistance. So there's a lot of things going on here that are typically not just impacting the vasculature on their own, but also leading to this kind of cyclic or holistic action in the body that's leading to hypoxic vasoconstriction and pulmonary hypertension.
So we can break this down into a flowchart to see not only how this happens. So how does something like a reduction in ventilation lead to poor oxygenation and then pulmonary hypertension? But also, what is this cyclic process here? So why is this so bad over the long term? So what we see when we have a reduction in ventilation is a reduction in oxygenation. So we have a reduction in oxygenation, which is basically going to stem all of the consequences that we see for this patient. And the longer this goes on, the worse it is for them. So this is why it's very common in someone who has something like emphysema, chronic bronchitis, um, chronic pneumonias, fibrotic lung disease, anything that reduces ventilation and leads to poor oxygenation is going to have consequences that in the short term are not as bad for this patient. Remember, there was a function here. It's to shunt this blood to areas of better oxygenation. But in chronic disease, we just don't see that, or we don't have that ability. So what happens, or one of the things that happens, is that this reduction in oxygenation impacts our vascular smooth muscle. One of the impacts that we see is we have a reduction in function of our voltage-gated potassium channels, which increases our intracellular potassium concentration, which will increase our resting memory potential and make us more prone to excitation of those tissues. So picture that vascular smooth muscle now wants to be excited more. That excitation leads to calcium influx, and the consequence is vasoconstriction. So we see vasoconstriction, and if that's happening chronically over time, not only do we have vasoconstriction as this is occurring, we're also getting that hypertrophy of smooth muscle in the chronic setting. So that's one of the factors here is when we're looking at how does someone end up with pulmonary hypertension, it's because they're chronically vasoconstricted because their potassium channels are not working properly. The other thing that we see happening here is this oxygenation, or this reduction in oxygenation, leads to smooth muscle endothelial ischemia. When we look at the smooth muscle, one of the things that we actually see here is an increased release of growth factors. So again, things like platelet-derived growth factor, our fibroblast growth factor, and this leads to an increased number of smooth muscle cells. And again, think about what the consequence is there. If I have an increase in smooth muscle cells, that's going to promote stronger vasoconstriction, which then will further promote hypertrophy of these cells, which is a big issue for this patient and is going to lead to an increase in pulmonary vascular resistance. One of the other issues we get here is that increase in growth factor is actually going to lead to an increase in collagen and elastin deposition, which will reduce our lumen size on top of this thick muscular tissue and the increased number of smooth muscle cells. So as we get hypertrophy of smooth muscle cells, and we get an increased number of smooth muscle cells, these things are also leading to a reduction in lumen size. So increased smooth muscle cells lead to a reduction in lumen size. The hypertrophy of smooth muscle leads to a reduction in lumen size. And then that deposition of collagen and elastin is also reducing our lumen size. So a number of things leading to just decreased space in that vessel for blood flow, which ultimately is going to lead to an increase in pulmonary vascular resistance, which is going to lead to pulmonary hypertension. Now, if that wasn't enough, the other thing that we're going to start seeing here is reduced production of our vasodilators. So nitrous oxide and prostacyclin are going to be our vasodilators, so we need those to cause vasodilation. And we see an actual increased production in our endothelin or our vasoconstrictors. So these two things together, if we think about the impact of both of these, is that we will, again, lead to an increase in vasoconstriction. I know we've got a lot of arrows here, but those arrows are important to recognize that this process has not only individual impacts, but those individual impacts are further going to produce the problems that we see here. So as this continues on, the ultimate consequence, so if we look at what the ultimate consequence here, it is this increase in pulmonary vascular resistance. So the big problem is when I promote vasoconstriction, which is going to push in on that lumen, or it's going to squeeze that lumen, it increases pulmonary vascular resistance. When I have anything that reduces lumen size, so as I try to shove more cells into this vascular smooth muscle or the area around the vascular smooth muscle, sometimes the only place to go is in. So I further reduce lumen size, I get an increase in pulmonary vascular resistance. One of the issues we see in people with chronic VQ mismatch is that we also get an increase in red blood cell production, which not only leads to us having now we have a smaller lumen size, but we're also trying to shove more red blood cells through that lumen, increasing viscosity, which further increases pulmonary vascular resistance. And the big issue here is for the right ventricle. The right ventricle is what is pumping against the pressure in this pulmonary system, and we get right ventricular remodeling. So this is the crux to cor pulmonale. And as that right ventricle remodels, we start to see a reduction in cardiac output, and the patient starts to enter a form of congestive heart failure. And the issue with this is that chronic reduction in cardiac output leads to compensatory mechanisms. We activate renin-angiotensin-aldosterone system, we activate the ADH system, we activate the sympathetic nervous system. And the end result or the end consequence of that is going to be either an increase in blood volume, which means now I'm pushing more fluid through a reduced lumen size, or the majority of these things are also going to promote vasoconstriction. So we're going to get even further vasoconstriction. And if we don't correct the underlying ventilation problem, and that's the key to this, is that when we don't fix the ventilation problem, then this only gets worse and worse. And when we look at a chronic disease like COPD, when we have chronic remodeling of the airway, chronic remodeling that leads to a reduction in ventilation, this process typically simply just gets worse and worse.